we know that first-line immune checkpoint blocker has improved outcomes in patients with metastatic non-small cell lung cancer. But responses to this treatment, which is now standard of care for a large fraction of these patients, can be seen in only 50% of patients, and eventually among responders, resistance develops over time. And so we really are in need of identifying novel biomarkers of response and resistance to immunotherapies. And our group a few years ago has reported that among patients who received first-line pembrolizumab and had a PD-L1 expression levels of 90 to 100%, clinical outcomes were significantly improved as compared to those patients with a PD-L1 expression of 50 to 89%. At that time, this study suggested that PD-L1 expression may act as a continuous variable and that higher levels of PD-L1 actually correlate with better outcomes with immunotherapies. But there are still no data about long-term benefit from these immunotherapies in patients with different PD-L1 expression levels, particularly at 3 or 5 year follow-up. And so in this study, we try to address the question, what's the clinical outcomes in patients who receive a first-line treatment with a checkpoint inhibitor, specifically PD-1 inhibitors, semiplumab or pembrolizumab, as opposed to patients who receive standard of care chemotherapy, for instance. And so in this study, we had 2 cohorts of patients who received semiplumab. This was a cohort from the EMPOWER-Lung-1 study, which was a randomized phase 3 study comparing semiplumab versus chemotherapy in first-line setting. The second cohort of patients who received commercial pembrolizumab. All these patients were treatment naive and had a PD-L1 expression level of 50 to 100%. In both patients treated with semiplumab or pembrolizumab, the response rate, the median progression-free survival, and the overall survival at the 3 year follow-up were significantly improved in this subset of patients with a PD-L1 expression of 90 to 100% versus those with a PD-L1 expression of 50 to 89%. By contrast, we didn't see any difference in survival outcomes by PD-L1 expression levels in the control cohort of patients who received first-line platinum-based chemotherapy in the control arm of the EMPOWER-Lung-1 study, suggesting that this biomarker is predictive rather than prognostic. We also learned in this study that tumors with a very high PD-L1 expression level of 50, of 90 to 100% have unique genomic features such as a low prevalence of NSCLC as marker for mutation, which has previously been shown to associate with resistance to immunotherapy. But also these tumors have low aneuploidy levels, which is another biomarker that has been shown to correlate with outcome to immunotherapies. And more importantly, tumors with such a high level of PD-L1 expression, of the one expression of 90 to 100%, also have higher density of CD8 positive T cells within the tumor, suggesting that these tumors may be immunophenotypically different and genomically different from those that have a PD-L1 expression of 50 to 89%. In summary, this study confirmed that a longer follow-up, the PD-1 monotherapy is an effective treatment for patients with a very high PD-1 expression level, and it can be a reasonable option which spares the toxicity of chemoimmunotherapy instead, which added, of course, the side effects of the added chemotherapy backbone. This study also has implications for how we think about clinical trial design interpretation, because we need to stratify patients by PD-1 expression levels, including 90 to 100%, since this is a strong predictive biomarker. And we also have implications for how we think about adjuvant and neoadjuvant immunotherapy, since we do not have biomarkers that can help us identifying those patients that really need perioperative immunotherapies.